Hey everyone, welcome to our in-person work in progress session. So I'm really excited to introduce Josh Best, who many of you know is a Regenstrief investigator. And we also have Paul Musey from the Department of Emergency Medicine that are going to co-present on an exciting project that they're actively working on. They have a PCORI letter of intent that was recently accepted for a full proposal. So this is something that they're actively engaged on, working on, and want some of our input on. So excited for active participation. We hope that this is engaging and we have a good discussion. So without further ado, go ahead.
Thank you, Rachel. Paul and I are going to divvy up the work this way. I'm going to do all of the general talking, and then he's going to answer all the difficult questions and get the feedback from you. So, so I'm really happy to be up here with Paul talking about our PCORI proposal for two-stage screening for health-related social needs. We have quite a few additional partners from both biostats, also from the School of Medicine. We have a patient rep who has worked with us on a previous project, and we're happy to have her as well. And our contact at IU Health, Kali Wanaki. I will mention as we talk about this, one of the things that we both want your feedback and ideas and suggestions, but one thing I think that would be exciting that I hope people think about is how we can leverage more engaged patients to do this kind of research, because this is really a requirement for PCORI to have a patient representative as an integrated member of the team. But yeah, so we're very excited to have Bree with us. All right, disclosures for CME. I think Paul's is easier, he has none. I have to say that I am a founder and equity holder in Upstroms, but it has no business, all financial, golly, that's tiny. All financial relevant relationships are listed and have been mitigated. Okay, so target deadlines. Like I said, this is PCORI. This is their broad pragmatic studies funding announcement. They put these cycles out every year. We put in a letter of intent that was accepted on October 31st. They do a initial peer review, PCORI does, before they invite you to the full proposals. And our proposal is due January 9th. As Rachel said, this is very much a work in progress. So I'll give you a little bit of background. First, I think folks probably know this, but screening for health-related social needs is really hard. And by health-related social needs, we're talking about things like food insecurity, financial strain, housing instability, transportation. Actually, and if you use the CMS definition, that also extends to intimate partner violence, which is also a challenge. But anyway, challenges kind of fall into four buckets. One is workflow. Whether you're doing this on paper, whether you're doing it electronically, how do you fit it into practice? It takes time for patients to answer these things. It takes time for clinicians. I think everybody is very much aware of survey fatigue and more paperwork fatigue that fits both directions. And it does cost money. Very few things that we do in healthcare are free, that come with zero cost to anybody. This is one that definitely does have a cost, particularly as we try to survey lots of people. We do know there's a lot of biases in health-related social needs screening. There's non-response bias. There's a lot of implicit bias in screening processes. There's a decent amount of qualitative research that says individuals' implicit bias around race, ethnicity will color who and how they ask these questions and who they're recorded for. And there's also a selective screening process. A lot of organizations say we screen everybody, but if you ask and kind of peel back and say, do you really screen everybody? They'll be like, well, no. We screen about 60% of adults at primary care. And do you screen on everything? Well, no, we kind of only screen. It's very selective on how it works. That, of course, has a whole bunch of challenges for screening. The other issue is just this is a numbers problem. Large percentage of patients are going to have health-related social needs. Most estimates in the literature assume that even in a highly commercialized population, you should be thinking about 1 in 3 patients will have something In a safety net population, it may jump more to like 70 to 90% of patients are going to screen positive for at least one social needs, and many of them will have multiple ones. And then timing. There is no agreed upon screening frequency. CMS and their Accountable Health Communities demonstration project shot for annually. CMS and their new quality reporting metrics is on every inpatient admission. That's a challenge. That's a lot of people. That's a lot of screening. That's a lot of frequent screening. And even then, it's not exactly sure if that's the right timing. Health-related social needs are known to change over time. They fluctuate and they move. It's not like a chronic condition, which can vary, but health-related social needs bounce around. So what we said was we need a solution to effectively and efficiently screen populations for health-related social needs. And what we have pitched to PCORI is two-stage serial screening, or what's sometimes called sequential screening. And that is very common. It's a standard health services epidemiological approach. The idea is you give a first screening test that is very low cost to administer. That's easy, broadly accessible, and then it identifies who needs in-depth screening for more stuff. So stage one, you know, if somebody's negative, you assume they are negative, or confirm you kind of, based on your stage one screening, assume the probability is that they're negative. You move to stage two if they're positive, and then you really do the determination. So it addresses a lot of the issues right off the bat. First of all, it addresses the numbers problem very easily. You are putting in something that's cheaper, that's much easier to screen a whole bunch of people, so you're accounting for that. If it's really cheaper and easier to do, you can do it universally at the first screen too, so you can address some of the time. So our research question is, what are the comparative benefits and risks of single-stage universal screening compared to two-stage health-related social needs screening for adult ED patients and providers? We can talk about why we're in the ED, but we're in the ED. So our proposed intervention is the comparator that we're talking about for PCORI is on one side is effectively universal screening. That is, every patient, adult, who comes through the ED would get screening. That's kind of the standard of care approach. Once they get the screening, they would be then connected to service providers. That's part of the grant process, is to actually ramp up and hire quite a few staff to do the in-person warm handoffs, connections to organizations. It's not just giving people a piece of paper and saying, go on. It's that warm handoff. The comparator is we would use predictive models or rules to figure out who should be screened. Stage two, then we would go back to the standard screener that's being used, and then we would still connect to services. So stage one has a lot of, that's kind of stage one predictive modeling. We could give it to everybody. It becomes really cheap, becomes really fast. Assuming it's effective, it would address a lot of these problems and reduce a lot of burden if it's still equivalent. So our outcomes, I put them here in two buckets. Ones that were kind of like, yes, piece of cake, easy, we know what to do. The second ones are kind of like we probably could do, but it's a little challenging and trying to figure out how to make it work. So first is, we need to have patients get services, right? It's almost an equivalency. We can't run out two different screening processes and one just people not getting services reduced, right? Like that's not effective. So they have to be equivalent. We would like to see changes in utilization, particularly appropriate utilization. I think a major concern is always about connecting patients after the ED back to primary care, so we need to get them in that space. So we want to make sure we're like targeting correctly. Some of the uncertainty ones. Obviously, we would like to have both screening approaches have patients getting their needs resolved, right? That's actually kind of the big goal. That's really complicated to do. Health-related social needs generally don't get addressed in a 15-minute visit. They require longitudinal follow-up. So just methodologically, how we would track and follow people for a very extended period of time is a challenge. Interestingly enough, about a fifth of patients across the nation, when you ask them, do you want assistance after they screen positive, will say no. A lot of people still say, no, I've got it, don't worry about me. So I think we would want to make sure that, and I don't know how to play with it, but knowing that is an important outcome. We're not trying to force resources on anybody, but understanding, are we being equitable across both groups? Or maybe in the targeted screening, we're able to actually find people who need help more and just be more effective with our resources. And then there's two other ones on here that are possible. Addressing health-related social needs is supposed to, or is anticipated to help patients through two paths. One path is you've met their needs and address their social issues, which reduces their stress, right? And improves their well-being. That's one path. The other path is you've made providers more aware and they're giving higher quality of care because they're able to tailor their care to meet patients' needs. Those are the two paths that people think this kind of work can operate through on patient health, though nobody's really clear on what it does. So there could be some way to measure providers to say, are the providers satisfied or feeling like they're increasing their knowledge through either approach. So we're still working through those. So how are we going to do this? We're proposing a step-wedge rollout using the 4 Indianapolis area IU Health EDs. We picked the smaller geography to maximize IMPC coverage so we can, have robust data. Also too, because we're hiring so many staff, it helps with the just hiring and management of a program to be somewhere a little bit more localized. And so we would be doing everybody's on universal screening for about 6 months, and then we would roll out each ED in phase over time with the new screening protocol to see if we can get what kind of changes. We do have prep year time for a whole bunch of stuff that has to be done on the front end, but that's kind of our approach, and we cross our fingers to see what happens. I'll turn to my colleague to see if he has what he would like to add or other questions.
I think the only thing I would add is that, so we talk about universal screening as kind of being standard of care, but I think what we're proposing is standard of care plus, right? So there is the ability for us to do these. We don't know how well the screening penetrates our actual patient population or how well it's delivered. That there's a difference between somebody looking at you in the eye, talking with you and conveying that they care, and somebody, yeah, so do you have a problem with housing instability? Which is, kind of like our nurses are, they're completely overworked. So I think what we're proposing with the use of community health workers will kind of step that up. Another thing that we also need to think of, so that's the definition of what universal screening is, and it's kind of a step up. But we really need to think about the workforce to accomplish that. And is it 24/7? Because we never close, right? And so if we're saying true universal screening, that we need to be able to provide those the services 24/7, but perhaps we have a 12-hour definition, right? Because you're unlikely to get matched with services after midnight, right? So we can make that case. And so those are some of the things we're going to be working through. And then also PCORI, now having a grant with them, we're going to have to really make sure that the clinical question and the gap that we're addressing is important to patients, right? Is the 2-step process as important to patients as the way it's delivered, right? Don't know. And so we're going to be having to talk to patients in order to be able to determine that. And so those are just some of the thoughts that I have. Open for questions. Yes.
There, can you hear me?
Yes.
This is great. I have a number of questions. I'm sure others do. So I'd encourage people to come up to the mic because we have some people joining remotely so they can hear us. Yes. So I think that this is a great idea, and this comparison is really good. You raised a couple of these points that I had written down of really being really important for PCORI, especially that patient engagement side is key, and the communities. It's not just the patients. I think it's also the communities, and so having a that engagement from the beginning around what those questions are, I think has got to include patients, but also the health system engagement and maybe the community-based organization engagement. So I wondered if you could speak a little bit about that. I know PCORI does a lot. They really emphasize this, that your outcomes were something that the patients or the engaged stakeholders also thought were really important. So wondered if you could speak a little bit about engagement. And then the second part is this sort of technical side of, and maybe that's related to the health system engagement, but how do you get the linkage to those resources and the engagement of the community-based organizations or the community health workers? Just sort of how is that, could you speak a little bit to the feasibility of that?
Yeah, absolutely.
Thanks.
So in terms of engagement of patients, we do have a patient rep that's associated with the study and has been involved in helping to craft the clinical question, but no question that we need to bring more patients in and more stakeholder kind of input as we craft the full application. And it's going to be a Herculean effort over the next 8 weeks to get that done. But I have a standing patient advisory board currently. I know Josh has access to patients as well. And my patient advisory board helped us craft the question for our current PCORI. And so that's something that we can engage them in to help us refine that question. And I'm sorry, the second?
What are the technical feasibility of the linkages with the resources?
Yeah, so here again, we're building the plane as we're flying it. Josh did a great job pulling a lot of people together in a short period of time to get the LOI submitted, and so now we have to actually bolt down a lot of the details. But we do have engaged IU Health partners that are interested in making this happen. I don't know if you want to speak more about that.
Yeah, I can share a couple of things. We'll first talk about the patient engagement. Yeah, I think we've been lucky. Paul's got a patient advisory panel. I've had patient advisory panels on my grants. I think leveraging them has been helpful. I really would love us to figure out a way to formalize that, to not have to try to always recreate the wheel every single time or re-engage people. We're lucky with Brianna. She identifies as a woman from an underrepresented minority, and she's also an informatics student. So she, first generation informatics student, so she actually gets everything we're doing, which is very helpful in terms of understanding the concept and can really add in. So, so that's one thing we've been leveraging. Our partner at IU Health is their actual population health side, where they're doing community engagement and screening and social workers on primary care. We're moving to the ED, one excellent partner in the ED, but it's also a greenfield for us at IU Health because they're not doing anything. So we're porting a lot of their knowledge over, and then while Paul's point is really critical about the 24-hour window point, that's also another reason why we're localizing in Indiana or Indianapolis, is because we just have a denser set of resources on which to draw. If we were across the state, other intervention programs have run into a problem because of this. I think there are some things that we will need to be subtle about and be more thoughtful about in our analysis. For example, most places have a real trouble dealing with housing. That requires physical location, space, partner. That's not an intractable problem, but one that is very, very difficult for anybody to handle on the healthcare side. So we may need to be thinking about how we look at some of our different needs in that regard to prioritize it. But that's part of the reason we're all here in Indianapolis, is management and availability.
Yeah, so like Rachel, I got a number of questions. I'll try to keep the number down. But yeah, I know, right? So first of all, I totally agree with you on the point about like the patient engagement panel. We've already had some conversations about maybe how we can convene and maintain one for the whole institute. So more discussions on that to come. A few methodological questions. So it looks like so first of all, are all 4 of these ED sites within the IU Health system, or are they also involving so no Eskenazi community, any other partners? Okay, so 4 sites within IU Health. So it looks like site 4 then is primarily your referent group throughout the whole process, since they don't implement till towards the end of the grant. Are they so you have a way to, are they a true sort of a peer for the other sites? Do you have any that are more rural, like, is it suburban and urban? Is it just the downtown hospitals? Like, yeah.
So we're having a polite academic discussion with our statistician who wants to randomize. I would argue we're not, yes. So we haven't decided on who's going to be the simplest, cleanest way would just be randomization and go. However, I do concur with you that that's possibly not pragmatic. I think possibly Site 4 is going to be driven by pragmatism too, about staffing and getting people on board and able to change workflows, right? I think because of the connections at Methodist, right, it would seem that Methodist might be one of the ones that would be easier to roll on first, right, for like the changes and things like that. However, we haven't figured those out yet, so
okay.
We haven't decided. Do you have a recommendation for us?
For a step-wedge study, you need to randomize the order of that, which would be,
right.
and that's the best methodological.
It is the best methodological yeah, that's so I think there's, methodologically you should randomize. However, I think there's a question that some people would raise about, can you really randomize 4? Like, the sample size is so small that we do have a problem that, and then there's the whole pragmatic.
So none of the other hospitals in the IU Health system will be doing universal screening during this time period?
Not from an implementation standpoint. Like our partners at IU Health are interested in doing this in the emergency department because they're not currently doing this. They're doing a version of this in primary care.
But okay, right. So you're not going to have any other referent groups.
But to your point that like West, North, Methodist, Tipton, whichever 4 hospitals, they're all kind of different, right? And they have different, they service different populations and they'll have different needs. And so you can't really control for that. And so that's where I kind of just, I agree with sales, like just randomize. I mean, like there's so much stuff that you can't control for. And so just jump in.
I have so many questions.
I don't, all right. Last question, and then I'll let Nicole go. But my other question was then on the social service agency engagement. So obviously you're connecting patients to services. Are you going to be able to find out who actually receives services, the fidelity of those services, any kind of feedback, closing the loop, any of that part of what you're attempting or hope to get out of this project?
That's the problem with the resolved need question, right? That's the whole problem with resolved need, right? Not only is it time, but it's follow up in the infrastructure to do that, and that's yeah.
I think the practical question is that if this is successful, are health systems going to invest in the back end trying to figure out like what happened to these patients after they referred? I think systems and clinicians are more concerned with the linkage to care and not necessarily owning the piece afterwards. And so I'm sure there's a certain way, at least in our questionnaires, where we can ask about if patients took advantage of those services. But I think there's going to be a little bit of logistical problems with fidelity, like
need an implementation scientist.
But the question I have, okay, so I'm thinking about both the question regarding sort of randomization, but then also going back to your very early slide about outcomes. Is that, I mean, is there a way that you could say, you know what, we recognize that these are all health-related, social needs, but for this study, we're not going to treat them as equal. That's the other piece, right? So if you if you're lumping them all together, like housing insecurity, but maybe just needing some help with utilities, those are really different problems to solve that actually may take sort of different amount of time and are going to have some variability based on your site, because there's going to be probably some places that are going to have a higher, your distribution of need is going to vary from site to site. So I wonder if you kind of narrow your definition based on sort of a conceptual model and then tie it back to a health outcome. So for example, like of the health related social needs, is there strong data that says this one leads to poor medication adherence, or this one leads to more ED visits? I mean, like, and narrow it to a couple, because I kind of worry that you guys know that you even mentioned it, right? Like, somebody who comes in the ED who's homeless, that is a much bigger problem to solve. The primary care, it will not be able to attempt to solve that versus, maybe some support from, social work can actually get something solved and started even before that person leaves the ED. And you've identified it as a need, but it's going to have a very different outcome for that person, both short-term and long-term. I just wondered, it just seems like it's a lot to define as one thing, especially to measure in a design like this, I guess. So. And I don't know enough about the literature to know like what the conceptual model is of those different needs and how you could tie it to an outcome,
Totally following what you say, but one of the challenges is CMS and the Joint Commission are not doing one-offs, right? They're not saying just deal with transportation. They're not saying they're doing it holistically, right? And so that does fit with some of but I do agree with you that there is conceptually, there should be some things that we,
Right.
like no matter how well you screen and identify people with housing issues.
Oh, yeah.
A 5-year grant on this nature, even if connection with the warm handoff of a community health worker or social worker, it would be hard pressed, I think, to fix housing. And so, in a long-term sustainable way. So I do agree that some of these may not, that's why they're fitting into the kind of distal outcome of uncertainty questions. I'm not saying that's a harder thing.
Well, you could potentially sell it on. I like the fact that you have, patients who are wanting resources because you also, you identify a need based on your screening tool and patients are like, I figured it out, right? But it is also somewhat unethical to identify a need that you can't solve.
I agree.
And so if it's something that, so you could sort of say, we recognize that these all get lumped together, but, our ability to test this in this setting with this community health worker model, is not going to be able to be even touched, and you're going to sort of wash out any effect. Maybe you could make some strides on transportation, but you're not going to be able to touch housing insecurity. I don't know.
No, it makes sense. The ones that could be handled directly within a particular, food vouchers can address immediate hunger needs, right?
Right.
Switching to free or generic medications can offset financial costs, right? Some of those things.
And one other thing, just having, worked more now, obviously with IU Health, is that it may be worth, when you're choosing your sites, just to kind of, if you haven't already, sort of do a kind of like a pre-implementation survey to see sort of what their culture is already with regard to doing these. Because, some places just already sort of do a better job at this. Maybe not in the ED as far as detecting it, but potentially having the resources to solve it. So.
Yeah, and I think some of the resources and the direction of that would come from the system because, they're interested in rolling this out. I think to your point about narrowing, I agree. So, CMS and these organizations are concerned about universal screening in that, we're screening for everything. I think one way that we could limit that, if possible, is to ask patients, right? That, hey, these are all the things that they want us to screen for. Here's what we have really good resources for. What do you think? And I think that would be one way within the article to say, or within the application to say that we understand, we can do this, we can have stuff in the background, but this is what our patients want us to focus on.
It seems that your intervention depends heavily on your level 1 screener. That first of all, it's got to be brief, otherwise you don't save any time. And then there's the balance of sensitivity versus specificity. If it's highly sensitive, it's not likely to eliminate enough people to make the 2-level screening worthwhile. If it's highly specific, you may miss people who need screening. So you're going to have to convince the reviewers that it's both sensitive and specific. Is it? Do you know that?
Yeah, so yes, so I think we can do what we've done on our previous work, porting that over. We can lean on literature where we've done models that are both sensitive and specific. However, if you look at kind of what the overall performance of a screening strategy is to do, first stage screeners really need to, the 2-stage screening model maximizes specificity actually. So your first stage really needs to be actually very sensitive. It can't be a rule out kind of thing. It actually needs to make sure you still have a lot of folks in that should be. So we're probably trying to maximize specificity on the first range. to get through. But we also have to come up with alternative strategies on how to work through that one.
Right, I mean, so the number of people it rules out has to balance the time it takes to do the initial screening.
Well, hopefully we could automate it. The goal is to have prediction modeling just roll through and have some sort of high risk flag or indicator so we can figure that out.
Okay.
So I have kind of a two-part question. First, are you going to use any additional data sources? Like everything you were discussing in the presentation so far really makes me think of the SAVI data set that the Polis Center has on Indianapolis and the greater Indianapolis area. Now, I understand that if you use that as a component, it is going to limit your generalizability because we don't have a lot of cities in the nation who have as comprehensive a social data set as SAVI. But I was wondering, like, if you were talking about making these predictive models for the initial stage screen, could you simplify it, simplify the work on your part by incorporating that data, but also make it more broad and potentially more specific by incorporating all the layers of analysis they have for particular areas of a city? So then, like, instead of having to do a patient initial screener, you could just have an algorithm possibly that incorporates their address and then pulls in all of that data from SAVI and says, like, okay, this area indicates these needs, and then check for those.
Yeah, so in the existing prediction models I was mentioning to Bill, we've used area level measures and individual level measures both to achieve perfection, achieve prediction. Some health systems are using area measures only to do as a first stage screening kind of approach in kind of a back-end way. While they contribute, the individual levels factors end up being much stronger predictors than the individual. But we would definitely include them and consider them because we've used them in the past and we want to keep as much informed as we can. Particularly as like I said with Bill, we need to maximize specificity. So when we change our parameters and emphasis, those may become even more important.
Okay, because I can see how, like, if you were able to narrow it down to a specific set of like likely concerns for a patient, then you could really much more easily do what Paul was suggesting, which is that asking the patient what they care about. Like, say, like, we think about these might be relevant to you. Are any of them, and what do you need? So, okay, cool.
I was just going to follow up on the question that Bill raised about the first level screener. So because you're kind of moving to the automated method, you've validated previously in a primary care population, is that right?
And we're building one right now in ED.
You're building one. I was going to say, you probably need to probably a part of this might be, at least initially, where you have an in-person counterpart that you could use to help validate your automated method for the ED population. Is that part of how you're validating your screener now?
So the way we have done our validation of screening is to administer for testing purposes, in which I think we probably would have to validate during our rollout, is we give two instruments. One instrument where we know the psychometric properties, that we know the reliability, we know it's not a gold standard, but it's as close as you can get to a gold standard without, pulling people's tax records and seeing what their finances are. Right. So we ask those questions in addition with the screener so we can then figure out the actual performance. Okay. And we would use that as the baseline against the thing, which then we could use to compare with area level measures. We could build various algorithms. We could even pilot a kind of simple screener, like almost that Bill was suggesting, like a simple question of, do you have any challenges or do you need someone? We could even build that in there to see how well that performs as an option.
Yeah, right, okay, because the other option would be to try to have, because the other thing I thought about eventually is if patients could answer that initial screen, like from a device ahead of the appointment, right? But I guess ED is more, or you can in the, but maybe when they register or something.
Yeah, you bring up an excellent point. So we actually just had a presentation on Vital ER. I think I may be blanking on messing up the name, but it's a new program that we're going to be rolling out in several of our emergency departments, which I call like the Domino's Pizza app. It's like this is how long you've been waiting. Here are your labs. But a platform like that could be used to engage patients around the screening. It's like, You're already engaged, you're clicking through, you're seeing stuff, want to ask you some questions and help to direct services. Now, it was not ready in time for this submission, but that gets back to when we engage our stakeholders is the question, how we screen or who we screen. So right now we've been talking about how we screen. Is it better universal versus this two-step process? That may be very important to patients, or may be more important to patients about how they're engaged. And so I think depending upon like how we write this over the next couple of months and any comments we get from patients, we have avenues for future work regardless.
So I have a question about your primary outcome related to the patients who have resolved social needs. In my mind, when you have a screening tool, the purpose is to identify patients who need resources. So can you walk me through why you think, whether or not they are identified through the universal or through the second screening, that might have an outcome on whether or not they have resolved resources? Because in theory, they're identified and they go on to the next stage. So why would the screening tool have an impact on whether or not something is resolved? And then my second question is more of a point, but I love that you want to look at the percent of patients wanting resources. I would imagine that your patient advocates would be very helpful for this, because we all understand that violence and financial stability, all these things are related to health. But as someone who grew up in a rural area, if I'm having financial struggles, I don't think, let me talk to my ED doctor about this or my primary care provider about this. So maybe this is an opportunity during the screening process to do some education with the patients that you do have tools to help them, because healthcare is not what people think of in the mindset as solving these socioeconomic challenges.
So thank you, Heather. Yeah, this is why there's kind of this struggle. Part of it comes back to Nicole's point of, if you're asking, you got to be doing something. Now, is the fact that the process is in place by actually connecting them to a community health worker or a navigator or a social worker, is that enough to satisfy that need, or do we need to go the next step and actually know resolution, right? That's where the motivation comes from. But I agree with you, right? A purpose of the screening tool is not to find out how many people got treatment from it. Right now, what we would want to know, though, in terms of making sure things are fair and equitable, if for some reason, oh my goodness, like the percent of patients who want services is very different after we do two-stage screening, or possibly that we introduce two-stage screening and nobody's getting resolved. That's actually informative, and the answer is I don't know what that means, though. It could mean we're just two-stage screening is finding a lot harder people to work with and we're getting more, or it could be two-stage screening is just screwing everything up and just making it more difficult. So I don't know, it's a challenge, because I think everybody wants to say, yes, we've got to act. There has to be some kind of action in response to the question, right? It's not simply a diagnostic study, even though it is a diagnostic study. I don't know if we can simply say it that way, particularly for PCORI.
I've got a question about your patient population. Having worked in the Regenstrief ER for 25 years, it seems like you've got different cohorts of patients. You've got people coming in with trauma. It could be a sprained ankle, a broken finger, minor trauma. It could be a broken leg. It could be a broken arm. It could be a broken head or something, kind of moderate, or it could be severe, multiple vehicle accident, multiple trauma, things like that. And then you've got people who are, they've got some kind of acute illness and they don't have another source of care. So they use it as an urgent visit. Something that probably could be done in primary care, but I don't have a primary care doctor, or it's nighttime, or it's a weekend, and I'm worried I don't want to wait until the next thing. And then there are people who actually don't have access to care, and they're using it as a stand-in for primary care. I'd be interested in knowing, with the current screening thing, do they ever screen people with trauma? Because if you're finding they don't screen people with trauma, then a priori having a screening instrument to screen out people who then don't get screened doesn't make a whole lot of sense. And people who have trauma may have difficulty following up on the recommendations because they got a broken leg or they've got other kinds of disabilities. I wonder whether you could be more effective to target people who might be in a frame of mind that to listen about trying to meet their social needs and be maybe open to doing something about it. The trauma bothers me a little bit because I'm not sure you'll get any, I think they'll dilute out the effect of your intervention.
All right, so I agree. So with trauma patients, yes and no. If I see a trauma patient comes in, they broke their leg, and I don't need anybody else involved, trauma services, anybody else, ortho, whatever, they're probably not getting screened. But once you start a trauma activation, there's so many other resources that come to this patient. At some point during their stay, especially if they're getting admitted, there's going to be some sort of screening or some sort of trying to figure out, okay, when we send this patient out, are they going to a safe environment? Can they walk up the stairs? So yes and no. But I agree that perhaps the two-stage process, the analysts in the background say, these patients that come in for this, they don't need to be screened. But we don't know that until you do it, until you compare it to the universal approach, which I said at the beginning, it's like standard of care plus. So we're applying this now to populations that generally aren't getting it because the way we decide to screen is universally biased. They're excited. Feedback.
Hi, I'm Meredith Green. I'm new. I've been here 2 months. I work in IUCAR. I guess I had 2 questions. One, I think, relates to the last question about who you're targeting, because it sounds like there's questions about how and who, and your secondary outcome of who's having preventable, avoidable hospitalizations and ER visits. And you think of the people who are frequently coming to the ER, many times they are the people who are going to have unmet social needs. And so to me, it felt like maybe there is some targeting because those might be the people who have the highest unmet social needs, are the people who are coming to the ER over and over. I do think this is important to try in the ER for that reason, because often people who are using emergency services are not engaged in primary care or might not have other access. And so I think it is meeting needs that should be met. So that was one kind of thought. My other question, and I know it's already been brought around implementation, has there been any prior work in the ERs with using outside community health workers interfacing with the staff in the ER? I just think that's an important thing to assess as well, like how are they actually going to integrate into these different ER cultures, in addition to what the staff think about adding these screenings. As you mentioned, ERs, all hospital staff are very overworked right now. And I do think this is an important role for community health workers. And I guess related to that, my question is, if it shows that there's some benefit of using the community health workers in this approach, whether, I know that's not your primary outcome, but what's kind of the sustainability like beyond this? Let's say you show one method is better, but you're doing it with the community health workers. What is there like a plan in place for how you might engage? I don't know all the Indiana Medicaid, Medicare rules. I know in California now there is some funding to support community health workers through Medicaid, but that's also in my mind as well, that part of having outside staff come in.
Absolutely. So a couple of things. So in the literature, there are quite a few reports of emergency departments bringing in ancillary personnel to help with social needs or any other kind of effort that they're trying to accomplish. And I think back to your question about, like, do we target the patients that come in or not? I'm agnostic to that question, but what I do believe is that we meet the patients where they are, right? So if you want to truly be effective at, for instance, with HIV screening, doesn't matter what you came for, you get opt-out HIV screening in the emergency department. So it doesn't matter what brought you in. And so somebody may have gotten into a car accident, but maybe that's because they're driving a 25-year-old vehicle that has no safety. And so perhaps there are services that they may be able to benefit from. Maybe not. We don't know until we ask the question. To the sustainability piece, the question is, I don't know. If we show that this is effective, especially a two-stage approach that you're not having to screen everybody, you can kind of predict who needs to be screened, and then you can link them up with community health workers who can help them navigate the resources that are available to them. If that's effective, I'm sure that there are health systems that would look at investing in that, because especially for all the reasons that the regulations are coming out, that they're going to have to deal with this in some method. And so I'm confident that if it's effective, that people will look at methods to sustain it.
Yeah, I'll add in one more part about, I agree we're trying to build in the time for implementing and integration into workflows and culture. We've done interviews with physicians, in ED physicians, some of which may practice around here, and nationwide. And the answer is, oh, they've gotten screened? Yeah, or should you do screening, or they've been screened? Yeah, that sounds like something the social worker should take care of. Or maybe the social worker should do it. You ask the nurses are like, yeah, that sounds like social workers. I think the burden that health-related social needs place on the emotion of physicians and the complication of care, an additional resource would be very welcome to be able to redirect for appropriate care. So I think there's not, but that just because there's the acceptance doesn't mean it fits into workflow automatically and other things. Not mention it, there's a giant IT component with IU Health here as well about making sure that this actually does its thing.
I have a couple of comments from the online chat. You mentioned that most people will say no when they are asked if they want help in the ED. Have you thought about reaching out with resources through the EHR or similar after 2 to 3 weeks? That way they are outside of the situation that brought them to the ED and may have more bandwidth to focus on things.
It's a point of, well, I'll let you answer, but it's just as a point of clarification, it's not most will say no, it's about a quarter,
Okay.
right? We'll say, no, thank you, I don't need services. But,
Yeah, no, and I swear that question was not a plant, but like one of the things that we think about is that just because you screen for it in the emergency department doesn't mean that you need to address it in the emergency department, right? And so if you can get that information into the EHR in such a way that you can connect people with resources that come 2-3 days later, it's like, okay, so right now we have Twistle that was sending out messages during COVID, hey, here are your COVID results, or okay, you screened positive for X, Y, and Z, please look out for a call from one of our team members in the next few days to figure out like how can we address this? Is this a good phone number for you, or how else can we contact you? So I mean, there's lots of different ways we can think about the linkage to care after the screening. And I think back to another point is that, yes, as an ED clinician, I would love if another team member could help with the screening and with the linkage to care, because I'm thinking about the medical. So I think if you ask most clinicians, nurses, or whatever, they would welcome the support of social work, community health workers in order to be able to help that. And I think community health workers allow us to kind of expand the population of people that, because I mean, our social worker workforce is also limited, so.
And I have one more just real quick. Someone mentioned about us accessing whether resources are being utilized. Maybe be a partnership with primary care may help with that by having another point of contact.
I agree with that, except for the patients who do not have primary care at all or don't have primary care within our system. And so I think whatever we need to do, we need to be able to collect the information universally on patients that are not enrolled, but that move through this pathway.
Great. I have another question for you guys too. Thinking about outcomes, and there's a lot of conversation here around the implementation of the intervention, and it's not totally clear how the linkage of care is working yet. I'm sure that will be described really well in the proposal, but it did make me think about your list of outcomes and that there are some missing around some of those important implementation outcomes. So, I've seen a lot of these types of interventions where at least one aim is really focused on the implementation of that, and that would get at the sustainability, and heard some discussion around a number of different potential outcomes you could add to that. and wrote down a few here too. But I think thinking about that context of sort of acceptability for not just the patients, but the providers and the health system leaders, and measuring that, having some sort of measure or some mixed methods where you could engage and have an assessment of sort of high implementation versus low implementation, if that's relevant here, depends on the specifics. But that may be not just at one level, it might be at the provider level, the health system level, the patient level. And then, things like that, the number of, PCORI does not like you to look at costs, right? But are there ways that you can get around that in terms of sustainability and thinking about, okay, the number of community health workers that were utilized, or the number of ancillary personnel that were utilized, the time it took different providers to do things, or the technical side of resources for either of those methods in comparison. So I wonder if there's ways, because I think thinking about the broader implications of this work, it's really important with all these health systems screening for social needs and these risk factors, but not yet having solutions for what to do about it. So I think looking to that future of people are going to want to know the answer of this important question, not just for how do they do this screening, but what are the resources that a health system might need to invest in order to address those social needs. And you can respond to that, but yeah.
No, I was going to say, no, I want to keep a running tally of costs and just not tell PCORI.
Right, yes. So yeah, there may be a side study pilot.
Right. No, because that becomes critical, right? That's, you can appreciate CMS saying as a quality metric, you're going to do this for every single admission, right? And I think people are saying that if it's admissions, the other settings of care are not far away. And that's a lot. I mean, if you're IU Health and have, like what, 800,000 patients, and that's a lot, that's real money, real fast, very quickly, yes. So.
Great.
I completely agree about the sustainability and being more thoughtful about the implementation piece and the outcomes that we actually have a meeting tomorrow to talk about outcomes. So.
Yeah, we're taking all y'all's feedback and putting it
great.
Run through tomorrow.
Well, this has been a really engaging discussion. Thanks, everybody. Thanks to our presenters. This is a really great example of an area where I think this aligns really well the Regenstrief mission. And thanks to the audience for all the participation. We'd love to do more of these in-person WIPs. So we're looking for signups. If you have an idea and you'd like to present across centers and getting this engagement across the Institute, please let us know and we will make sure to add you to the schedule. I think it's a great opportunity to do this at the exact time where you guys are doing this, where, or a little bit ahead of time, where you have a few months before a big grant proposal and you can get feedback and build that in. So great, thank you.